I've evolved a lot over the last 20 some odd years, and I definitely have learned from not only my own mistakes, but the mistakes of thousands of men and women who have unfortunately been burned by this $3.5 billion a year hair loss industry. Now, the truth is, two-thirds of guys by the age of 35 will suffer with some degree of hair loss. 40% of hair loss sufferers are women. And the truth is, most everything that's being sold out there that claims to stop, prevent, or treat hair loss is complete nonsense. Will not help you in any way, shape, or form. That's just the way that it is. So if you're just tuning in for the first time, if you are listening to us on iTunes Radio or Stitcher Radio, if you are watching us on Daily Motion or through the guys from Queen's Network, if you're watching us through the Bald Truth, or if you are now listening to us on Clear Channel, iHeartRadio, and this is your first time, understand that this is your safe place. I'm not here to sell you anything. I'm not here to bullshit you. I'm here to give you the facts. And in some case, you may have to edit it out for Clear Channel. I'm not sure. And I'm here to guide you in the safest possible direction when it comes to anything and everything hair loss. Now, tonight we have a really special guest, and I want to bring him on as soon as I can, in the next 2 or 3 minutes, because he has a limited amount of time that he can be with us tonight. But this is a guy, when I first started to research my book back in 96, 97, when I knew that I was going to get this book deal, and when I realized that, I had to make a decision on whether or not to write a chapter on surgical hair restoration that was going to completely lambaste the entire field. Because you have to understand, at the time, everything that I was seeing was crap. Guys' lives were literally being destroyed. Every company that invited me in, every clinic, every doctor, to look at their work, they were saying they were doing one thing. I was seeing something else with my own eyes. And what I was seeing back in 96 and 97 was that surgical hair restoration did not seem to be a legitimate option, in my view. And then I met Dr. Robert Bernstein. And he showed me a technique and the results of this technique. And the technique at the time was follicular unit transplantation that blew my mind. I had never seen natural hair transplant results before. I had never even imagined that a hair transplant could look like this. And it's really because of Bob Bernstein that I decided to kind of change my point of view when it came to surgical hair restoration. And I found that there were 11 doctors doing the same procedure that Bob was doing. And it was that month when I first met Dr. Bernstein that not only did I decide to write a chapter discussing follicular unit transplantation and its benefits compared to all the other techniques that were being performed back in the day, including flaps and scalp reductions and just, hair lifts and all this crazy stuff that guys were doing. But it also gave me the idea to create the first recommended list of physicians that ever existed in any field of medicine. Now, as time has passed, obviously the industry has evolved greatly. The vast majority of the work out there, I have to say, even by some of the doctors who are not recommended by our organization, is pretty good. We're not seeing, or at least for a while, we weren't seeing a lot of the disasters that I saw years ago. But I'm starting to see things kind of, I guess the word is devolve. Back in 1998, 99, I was contacted by Dr. Ray Woods. who was performing a technique at the time called the Woods technique. And he was extracting one graft at a time using very small punches and moving those hairs, those intact follicular units, without leaving a linear scar. When I first saw this, I thought that this was going to be a game changer. And I spoke to many doctors here, or several doctors here in the U.S., and everyone said I was crazy. Again, getting back to Bob Bernstein, initially, I think he looked at it with a jaundiced eye, but he embraced the concept early on. And then him and Bill Rassman ended up writing the first paper on follicular unit extraction. And I can say that the rest is history. But as things have evolved, and I'm going to get back to the point where I said that things have kind of devolved, the market itself, consumers, online consumers especially, are really driving the market. And there are a lot of doctors who have incorporated FUE into their practice just to compete, just to say that they're utilizing this technique, that they're offering this technique to patients. And some of the work that I'm seeing is disastrous. I'm talking about stuff that was done in the last few months. I can't even believe my eyes. Now, the idea of creating a device or a machine or a robot to kind of take certain variables out of the equation when it comes to surgery, I think is pretty compelling. Now, there's a big debate about whether or not these devices are actually good for the field or actually going to be damaging patients. But if anyone knows Dr. Bernstein, they know how conservative and how ethical he is. And Dr. Bernstein has embraced the ARTAS Robotic Hair Transplant system, or the ARTAS robot. And I wanted to bring him on the program tonight to discuss why he's chosen to go this route and why he believes that this is really the future of follicular unit extraction, hair transplantation in general. And I have to say, before I bring him on the air, no matter what your thoughts are on the subject, no matter what you diehard hair loss geeks, and I'm one of them, I'm one of you guys, thinks, this is the way the industry is evolving. Period. Good, bad, or indifferent, these devices are what's going to be offered in just about every practice eventually. So I wanted to bring Dr. Bernstein on to talk about, why he's embraced this, why he's gotten involved with the company. And, he's a really trusted, one of our founding members of the IAHRS. He's a really trusted hair transplant surgeon. And I thought to myself, when I found out that he was getting involved with this company, that there's got to be something to this. Let me see. I think that this is Dr. Bernstein. Let me see if this is him. Hey, Dr. Bernstein, is that you?
How you doing?
Hey, I'm fine. How are you?
Nice to be on the show again.
Listen, it's great to have you back, and I'm glad. I know you only have about a half an hour, so actually about 20 minutes left now. So let's get straight to the point. You heard my opening. You kind of know how I feel about the way the industry is moving, the direction the industry is moving in, and also my concern about now that these devices are really starting to become a bigger part of the market. I believe that these devices are getting into the wrong hands. Now, let's just start with, why you've embraced it, and then we can go on and talk about, how the industry is kind of evolving.
Sure. Follicular unit transplantation via strip was a pretty straightforward procedure. And once we figured out how to use microscopes to dissect out the follicular units and train the staff on microscopic dissection, it was pretty much a slam dunk. It was just a question of other doctors, embracing it and patients understanding what it is and demanding the procedure. Right. With follicular unit extraction, it's really a much different animal. The technique is very, very tricky. And the reason why it's tricky is because the dissection is done essentially blind. Follicles change, the hair follicle changes direction as it goes, deeper in the skin.
Right.
And also the hairs that comprise a follicular unit kind of splay outward. They fan outward. And so it's very tricky to get a very small punch around an intact follicular unit. And when you do this by hand, thousands of times, it's really, really hard for a physician to concentrate and be consistent and not get bored out of his mind.
Sure.
And then also you don't have all the visual cues that you have under a microscope. And so this repetitive procedure lends itself to robotics. And we tried many, for years we worked on the technique, first with a sharp punch, then a dull punch, then a two-step technique where we used a sharp punch to score the skin, and then a deeper punch under it. And each got better and better, but it never was really consistent, and it certainly was very, very dependent upon the user, the patient, and even just the day, how you were feeling that day.
Right.
And so this procedure lends itself to robotics. And I first learned of the robotic procedure very early in 2011. And when I first saw the robot, it just kind of made total sense to me.
Well, listen, there's no doubt that when it comes to any type of surgical application, this seems to be one type of surgery where robotics really makes sense. To be able to like you said, it's a laborious procedure. You have to really be able to concentrate. The fact that a machine can possibly do this repetitive motion thousands of times and have the ability to, see that follicular unit and to extract that follicular unit intact, it's absolutely amazing. But the biggest issue is, and I don't mean to cut you off, there are physicians out there, and there are, the naysayers out there that claim that, there's no way that a device like this could replace the human touch.
Well, it certainly does.
Okay. All right.
I've been doing follicular unit extraction for years, and doing it robotically now. When the robot first came out, it wasn't nearly as good as it is now. It's now 3 years on the market.
Right.
And we've had at the beginning we did just a couple of cases with it. Now we're using it for almost half of our patients. And the company is in the office when we're doing the procedures, and we're constantly, the R&D department. And so we're constantly tweaking the system, changing the optics, changing the rotation, the angle, the depth. And a lot of impressions that doctors got, I think, of the robot were through 2-3 years ago.
Right.
And it's really, really slick now. And it's to the point where in many cases we're actually getting more hair than sites. And so what I mean by that is we're able to preserve the follicular units so well that we can harvest larger follicular units and get more hairs per graft than we need. So we have to actually divide them up to get single hair grafts.
Well, what about the concern that some physicians are putting out there that, the size of the punch really doesn't lend itself to the most elegant procedure, and that there's going to be this possible peripheral damage to adjacent follicular units and a larger field of scarring with each punch. Does that make sense? Is that true?
The robot, when it originally came out, was a 1 millimeter sharp punch and a 1.2 millimeter dull punch. And I developed the smaller punch, and we started with the first ones about 1.5 years ago, using a 0.9 millimeter sharp punch and then a 1.1 millimeter dull under the surface, and that seems to be perfect.
So why don't you explain to our listeners and viewers how the punch actually works? Because obviously the smaller punch is what's scoring the skin, correct?
Right.
And then how does the other punch actually go in and grab the follicular unit?
So the idea is actually quite interesting. The idea of a two-step procedure the concept was by Jim Harris in Colorado, and he actually came up with the SAFE system, which does something like this with a handheld unit. And the way the robot works is that it has a sharp two-pronged punch that goes down about a millimeter through the skin. And the reason why you don't start with let me just back up. So the idea is that you have a sharp punch that cuts the skin, and then you have a dull punch that goes deeper in the tissues because, as I mentioned before, the follicles kind of splay outward, and you want to gather them into the hole, the lumen of the punch, rather than cut all the way down. So on the surface, the follicular units are tight. They're gathered, and they splay out. The hair follicles splay out as you go deeper into the tissue.
Right.
So if you use a sharp punch on the surface and the deeper punch below the surface,
you're not going to transect the grafts.
You can cut the surface without transecting the graft. The reason why you can't use a sharp punch all the way is because the angle of the follicle is around 30 degrees on the surface. So if you start with a dull punch, it kind of skids along the surface. So the way the robot works is that the smaller punch has prongs, and it goes through the surface and creates a mild suction. And this stabilizes the skin. It also can sense scalp movement, patient movement, so it can move with the patient. And then the dull punch goes around the outside of it.
I'm actually glad you brought up that point, because that is one point that one particular doctor keeps bringing up online, that just by the basic, just because, when a patient breathes, the patient's head moves. And,
right.
His point is that, a robot or any kind of mechanical device isn't going to go along with that movement. And you're telling us that actually it's able to sense that movement.
It absolutely does.
Wow.
It absolutely does.
Now, that's amazing. I think that's actually a revelation, and no one is talking about that online, and I think that's very important.
Right. Yeah, I mean, just the technology is really unbelievable. And so, the consistency of the robot, especially with these smaller punches, is great. For African Americans, we still use the larger punch. And it's kind of analogous to what we do by hand.
Right.
Where, people that have, very curly hair, the follicles curve under the skin and you need a wider punch so you don't have transection.
So what about these claims? Now that you're saying that you're using a 0.9 millimeter punch as scoring the skin. So what about these claims that certain doctors are making that you're going to be leaving a larger field of scar tissue? Obviously, that's not the case if you're using a smaller punch.
No, it's not the case. And it heals perfectly. And, the idea is to capture the whole follicular unit. And, I'm obsessed with that.
Yeah.
And, we've found that, with the 0.9, 1.1, you get the whole follicular unit. And the other thing that, is interesting is that again, the robots evolve, so we do all the beta testing. So in our office, we don't use one-hair grafts. We program the robot so it skips over the ones. Right. And that's what I was alluding to before. So if you're making a hole, it doesn't make sense to go for a 1. You go for a 3 or a 4-hair graft. And then, because our staff is so good at microscopic dissection from FUT, we'll take that larger follicular unit and a 4-hair graft, and we'll dissect off a 1. So we'll use that for the hairline, and we can get, twice as many grafts with half as many holes, much less wounding. And so it's really those kinds of nuances that we've been able to build into the robot as it's evolved has really made it so much more robust.
Well, I mean, you made a point, and you recently wrote a paper, or you wrote an article for the Hair Transplant Forum International, and you also, you made a point earlier saying that a lot of what's being written about and a lot of what the doctors, some of the physicians out there think was based on what was happening 3 years ago. So now that all this is coming to light, and now that I'm sure you've shared this information with your colleagues, and I'm sure Restoration Robotics has shared this information, why are people so resistant? Or why do you think there's a lot of guys out there saying that, this really isn't the way that the field should be evolving?
Well, Spencer, it's interesting. You remember way back in, I think it was 1996, 1997, when no doctors wanted to buy microscopes?
Yeah, I do. I do.
It's the same thing.
So it's interesting to see how many people are resistant to things at the beginning, and then once they embrace it, they realize, wait a second, this is really the right way to go.
So I mean, if you see the robot, the current iteration, it's pretty amazing. And but to get back to your question, the robot costs a lot of money for the doctor, so you have to lay out a lot. A lot of doctors don't have that kind of volume of patients, and then also you pay per click. In other words, the robotic company gets a cut on every graft that's harvested.
Yeah, but there's also a lease option. And let's face it, I mean, the cost of an average hair transplant is going to be $7,500 to $12,000. I think they're leasing it for what, $4,000 a month? I would say that any reasonable hair transplant practice could afford to lease that device.
Right. So Spencer, I'm agreeing with you. What's happening is that the doctor looks at it as, this company is getting a percentage of every graft that's harvested. To me, I look at it differently. I looked at it, wow, that's great. The company has a stake in the game, and they're going to want to make sure the robot's functioning, we get the upgrades, all that stuff.
True. Yeah.
I'd much rather have the company in bed with me than it's like when I did general dermatology and the company sold me a laser and then they weren't around to service it because the sale was done. So in many ways, having the company as your partner is actually good in this really high-tech, type of device.
There are patients who are calling physicians' offices. There are patients who are contacting me who are asking about either like the NeoGraft procedure or the ARTAS procedure. And there's this kind of confusion in the marketplace where consumers kind of, instead of looking at these devices as what they are, they're tools for physicians and their practices to use to perform surgical hair restoration. They're kind of being marketed as a procedure. So I think there's a lot of confusion in the market. And I think people now think that the NeoGraft is kind of similar to the ARTAS. And, maybe you can kind of describe the differences to our listeners because, we're in the know. So obviously I know what the differences are. But a lot of people believe that it's that they're very similar. Yeah,
Spencer, that's a great point. I mean, the most important thing is that the ARTAS, at least at this point, is just a harvesting system. And, follicular unit extraction, the actual extraction part, is only one part of the procedure. I mean, you have site creation, graft placement, and then the most important part which is the planning, the patient evaluation, checking patients' densities. I mean, it's just there's so much more to a hair transplant, and so the thing, as you said, is just a tool, and it needs to be in the right hands. And it's up to physicians. We have a fiduciary responsibility to do what's best for patients, and societies are supposed to regulate that, et cetera, et cetera. So there is because all these instruments are new. It's really hard for the public to get their hand around them, especially since marketing and everything is so slick.
Right.
And the NeoGraft machine has been around a long time, and basically the NeoGraft is I think it's almost the worst of all worlds. It's a handheld device. It's a sharp cutting, single step, high speed instrument that uses suction to pull out the grafts. And if you've ever seen a FEW procedure, when you score the graft, when you do the cut with the punch, whether it's by robot or by hand, you're only cutting the sides. So the bottom of the graft is still, attached to the underlying skin.
Right.
The underlying, actually, the connective tissue and the fat. And if you gently pull on the graft, you can kind of tease it away, leaving the bottom intact. But if you use suction, you'll very often shear the thing apart. And so a suction instrument, which is what the NeoGraft is really detrimental to grafts, besides the fact that the suction dries out the grafts.
Yeah, I was gonna say there's a lot of concern about desiccation or drying out of the grafts.
And the other problem with shearing the grafts is then the grafts come out, but then they have to go back in.
Right.
And in order to go back in the scalp, if the bulbs are either damaged or fragmented or fold over when you put them in the scalp, it's obviously going to be a terrible result. So you have doctors that are not necessarily skilled, have to use a handheld machine, which is extremely difficult, and then the technology in itself is not good. So NeoGraft seems like it's high tech, but it's really not. It's not robotic. It's handheld. You don't have good visualization, and the worst thing is that it's suction and just a single sharp punch.
Well, I mean, there are physicians out there who are definitely going to disagree with you, and they're going to say that in their hands, the NeoGraft has been a great tool in their practices, and there are obviously they have, there's plenty of guys out there that have had a procedure performed with a neograft who have, good results. So I'm sure, in some cases, I mean, obviously, listen, you don't want to implant any garbage, but I'm sure in some cases, I mean, what percentage of the grafts do you think are okay in an average neograft procedure? I mean, do you have any idea? Have you actually sat there and watched an entire procedure and taken a look at the grafts?
I have watched, and and there's a lot of damage, and also it's hugely patient dependent.
Yeah.
If you have a patient with thick, coarse hair, you can basically do anything and they come out.
Right.
But it's the bulk of these patients and the patients with fine hair and slightly loose scalps where these things come undone. And so it's so hard to just look at one case and make a judgment. But I think that in medicine, there's always two things. One is the statistics, and the other is just the idea. And I think that if you understand how a hair transplant works and how follicular unit extraction works, I mean it's pretty obvious that things like suction and sharp punches and things like that are not going to be as good as doing it by other methods. While I was waiting for your call, I thought you were going to ask some questions about the growth of the industry and the census and stuff like that.
Right.
So I was looking at the last IAHRS census, and one of the things that I was really struck by that I never noticed before was they look at the amount of procedures done in busy practices and in small light practices, and they break them down by medical and surgical. And it turns out that in practices with low volume, the medical and surgical patients are almost even, where in busy practices where doctors have a lot more experience, the ratio goes way down for surgery to medicine.
Yeah, sure.
Essentially what that is that these new guys that are doing...
They're just taking anybody on.
Yeah, they're doing procedures on everyone that walks in the door.
Yeah, listen.
And I think the whole conversation really should revolve around how to get doctors that are interested in hair to learn hair, or don't bother. Because this is, as you know, it's a serious business where these young people are really mutilated when their procedures are bad. And FUE, FUT, all of them in the wrong hands or on the wrong patient can ruin someone's life.
Look, I know a guy here in Los Angeles. He's a really great board-certified plastic surgeon. He got a hold of a neograft. He put up a website. Now he is a hair restoration specialist. And, he's been in contact with me. He's a really nice guy, and I think he does, incredible breasts and noses and chins, but he's never performed hair restoration. And he tells me how excited he is to get into this side of the field. And I'm thinking to myself, God, I really just hope that he took some time to really, see some procedures, learn how to do it correctly. Now, I don't know him that well, so I didn't really get into it with him. But this is what I'm seeing. I'm seeing it more and more. And I have to tell you, Dr. Bernstein, I believe, and that's why I mentioned how the industry is kind of devolving to in some respect, that we're going to be seeing a lot more walking wounded now that these devices are in the wrong hands.
Yeah, I mean, I agree with you. I mean, they're just general trends. And, medicine, the more, medicine gets tougher to make a living,
right.
More people are doing cosmetic procedures. It's pervasive in all fields. Yeah. To decrease the cost of medical care, they're kind of going down the food chain where, physicians do less and less, and there's more, physicians' assistants and nurses, et cetera, that are doing more and more of the procedures.
Do you know a simple thing, which seems simple, like injectables? Do you know how, necrosis from injectables is on the rise? It's growing exponentially. And in my view, it's because people who are relatively untrained are being hired by these doctors to do these injectables, to inject Restylane and Botox, and people are being harmed, and they don't even realize that this is a possibility when they walk into the office. They think it's just this innocuous procedure. Right.
Well, it's the duty of the physician to speak with the patient, give the informed consent, etc. Just like the many practices where they have salesmen, do the consult, and then at the back end, the doctor walks in just to kind of smile and sign off on it. And really, the doctor's duty is really the front end too, to really make sure that the patient understands the procedure. That's the art of medicine, and but also takes the most time.
But sadly, that's just not the reality. There are guys like you. There are other guys who are part of what we do. That's why it's such a relatively small number compared to the entire field. Right. And it's frightening. It really is, Doc, because I'm telling you, and I'm seeing it now. There was a time, probably about 5 or 6 years, where the reports of really bad work. Now, there were guys who have had unrealistic expectations that have contacted us. But I'm talking about the pluggy work, the really bad work. We weren't seeing it. I'm seeing it again. I'm seeing, hair transplants that aren't growing. And these are all, most of them are FUE procedures.
Right.
So, listen, you're right. I mean, what are you going to do? You do what you do. You do it the right way. You try to guide your patients by providing them with, all the information they need to make an educated decision. But there are plenty of doctors out there, sadly, that, they need to pay for their kids' private school tuition and their Mercedes-Benz payments, and they feel like they're under the gun, and, their medicine has changed, dramatically. It's going to get even worse. So when they see these patients walk through the door, they don't necessarily take the time to educate them because they want to get them in the chair.
Yeah, and also the problem, with the hair transplants is that there's a lag of a year between the procedure and really when you can get a sense that, things went wrong.
Right.
And, often the patients, feel guilty about just doing the procedure. They go on to someone else. They don't complain. They don't often even, go back to the same doctor.
That's true.
So service, like the Ball of Truth provides an incredible service for people to actually speak out and feel like they have a community for people that have been harmed.
Yeah.
It's just the psychology of men, as you know, they keep things secret when there's a problem.
I know that you're still obviously a huge proponent of follicular unit transplantation, and you stated earlier that about 50% of your practice is FUE, done with the ARTAS, and I'm assuming the other 50% of your practice is still FUT.
Right.
So, we've spoken about this before. I'm still a huge believer that, FUT is really an important procedure that shouldn't be lost.
Yeah, I totally agree. I think that the best way to think about it, and the way I explain it to patients, is that FUT is going to give you the most volume for the amount of donor hair used. And the reason is that when you take a strip, you're taking the mid portion of the permanent zone. You're going to take a strip that's maybe a centimeter and a half in width. When you do FUE, you need an area 5 times that height so that the hair is being harvested from the less than ideal area. The further you go from the mid portion of the donor zone, the closer to the neck and towards the balding area is going to be less stable over time. So the quality of the hair, by definition, can't be quite as good. Also, you're never going to be able to get the accuracy of good microscopic dissection with a punch, regardless of whether it's controlled by a robot or not. So the basic procedure should be, in my view, follicular unit transplantation via a strip. But there are many situations where a line is not having a line scar is preferable, and so what we do is we have the FUT as a default, and then if there are reasons to do FUE, we do it. It turns out that many people want to have the option of keeping their hair very short. They don't want to have any constraints in exercise. They don't want to have the risk of a wide scar, and especially in younger people who are physically active, a widened scar is actually a very real risk. It's a greater risk in Asian patients. Certainly, younger patients are now much more physically active.
And Asians keloid more, right?
I'm sorry?
Asians tend to keloid more than Caucasians,
yes.
right? Yeah.
And so they're great candidates. And so and sometimes people just don't want the stigma of having a line scar. And so that, unfortunately, there's also a scare against FUT because FUT both is not always done properly, and then it's also, people hype against it if they only do FUE.
Well, and that's the thing. Now it's looked at as an archaic procedure, that there's no place.
In Europe, the vast majority of doctors are now doing FUE.
I know.
And it's it's almost, malpractice to do a strip. I mean, if you do a strip and screw up in Europe, it's a problem.
No, I know. Listen, and everyone thinks that the guys that are continuing to practice and continuing to perform strip are doing it for some nefarious reason. Either they're lazy or they just are able to do more strips in a day. And, I try to tell prospective patients, I try to tell my listeners and my readers that, there's no way, and you said it, you cannot get 100% of that sweet spot, that DHT-resistant sweet spot, with FUE. I don't care what kind of crazy math some of these doctors are putting out there. It's not going to happen. So, if you want the most bang for your buck, and if you want to get the most hair moved, it's probably best, if you are the right candidate, to do a combination of both strip and FUE.
It depends upon so many factors. Sometimes
Sure.
when you do multiple strips, the scar starts to widen. If that's a constraint and limits you.
Right.
It really depends. But yeah, if you're going to get the most bang, the most hair, you would use a combination of both.
Yeah, and I think that it's unfortunate that, listen, strip is going to go by way of the dodo. There's no doubt about it. We see where the
problem is that new doctors are not, it's hard. When you can do FUE, even though it may not be appropriate for all patients, you don't need a big staff. You don't need to be trained on microscopes. And so the barrier to entry is actually much lower.
That's right.
But to build a team of 6 or 7 dissectors is very formidable for new doctors.
But what I find interesting, and that's a great point, is I spoke to an IAHRS member the other day who went in for his 3rd hair transplant surgery, and this is a guy that a lot of his practice is FUE, and he chose to get a strip. Now, obviously, he's already had a linear scar. But, this is a hair transplant surgeon, and he made that decision.
The other thing that we discuss with patients, and it's not, talked about too much, is, you have a very wide band of harvested area with FUE. And so in a young person, you don't know how bald they're going to be. If someone becomes a Norwood 7, that donor fringe is going to dip down below the area that was harvested,
right.
And you can see the stipples from the extraction. And although it's certainly not anywhere as near as, unsightly as a line scar, you can still see it.
Right.
Where if you have a line scar, it can easily be buried in the fringe if the scar is, placed in the right spot. The other thing, too, is that as people get older, the chances of having a widened scar go down significantly. And so really FUE has a very, very strong place for younger patients. And, older patients, they have much more balding and need the most volume, then, strip becomes more powerful.
Let me ask you, Doc, do you think that strip is just going to go away eventually? Even though it's a very viable procedure, and in many cases it really probably is the one to perform.
It seems like if you look at the numbers, it seems like FUE is increasing in market about 5% a year.
Right.
So unless that changes, in another 7 years, it's about 35% of the market now. FUE.
Right.
In those 7 years, it'll be gone.
Well, and you made a good point, and this is the way of the world. I mean, the new guys they're not even considering learning how to do a strip for the reasons that you pointed out, and also, out of pure marketing, reasons. It doesn't make sense for them to get into learn a procedure that is marketed as as an antiquated procedure.
Sure. Unfortunately, FUE, it's a newer procedure. It's not necessarily better in all cases, and so it's really hard for the patient to sort that out.
It's hard for the patient, and the fact is, the reason it's hard for the patient to sort that out is because FUE is being marketed in a very specific way. It's FUE versus strip. It's no scar or scarless, which is, we know the procedure is not scarless, compared to or versus having a linear scar in the back of your head. So in any consumer's mind, if they don't understand the nuances of the procedure, it's a no-brainer. They're going to pick the procedure that leaves no linear scar, period. State of the art, and that's the way it's being marketed. There's no changing it. But I am glad that you're involved in really helping to develop this robot, because you've been doing this. How long have you been doing transplants now? 20 years?
Full time since '95.
Full time since '95. And you've seen it all, Doc. And I think it's great that you're involved. And I think it's important. I don't know if we gave full disclosure prior to you coming on the air, but you are now on the board of Restoration Robotics. Is that right?
I'm an advisor.
An advisor.
To the, right.
Okay. So, I mean, and I'm glad that you are, because I don't think they would have gotten to that iteration where they're using, the smaller punch. And, initially, I think when a machine like this is developed, it's really they want to be able to, at least at the first iteration, their goal is just to be able to get the hair out precisely. They may not have understood, and I'm going to repeat myself, the nuances of the procedure and different punch sizing and how that affects future procedures and how that affects the way the scalp is going to look. And but I think initially the machine was developed with Jim Harris, right?
Yes. Yeah, it was based on, as I said before, it was based upon his two-step technique, the sharp, blunt technique.
Right.
So it really took the best of his ideas and automated it. And so that's it's a great instrument.
Well, this is what I can say. And for the guys who are watching from Restoration Robotics, there's no doubt in my mind that your robot is the future of this industry, good, bad, or indifferent. And I am not making any judgments here. I have seen some good results from the ARTAS. I know that Dr. Bernstein is working with you guys, and it's exciting that you're creating smaller punches. Do you think you're going to get to even a smaller punch at some point, maybe a 0.8?
I think that this, is probably the sweet spot in size.
Right.
I mean, it's good. Again, one of the beauties of this size punch is that we can get larger follicular units, and then with the smaller, so there's less transection.
Right.
And then you use a microscope to get individual hairs. So I probably not. I think that we try different sizes. This seems to be ideal.
Now, before I let you go, I think it's important. I know this isn't available yet, but you have worked on a way to create recipient sites with the ARTAS system as well. You want to talk about that for a second?
Sure. So the recipient site creation is actually the actual making of the sites is kind of a no-brainer for the robot to do. It can do it, so to speak, with its eyes closed. It's easy.
Right.
But the interesting part about recipient site creation is it lends itself to the design of the transplant, which is then a very, very nuanced, complicated thing. And so Restoration Robotics has developed this called the ARTAS Hair Studio to allow the doctor to take the physical image of the patient and then convert it into a 3D image, computerized 3D image, and then design the hair transplant first on the patient and then to tweak it on the computer. And so it's still in its infancy, but it's fun, and that's going to be obviously the wave of the future. The importance of making sites with the robot is not necessarily to actually do that, but eventually we hope that the robot will be able to insert the grafts, do the whole procedure, and to insert the graft, it has to make the site first. And so the site creation is really the intermediate step for the long-term goal of automating the major three parts of the hair transplant.
So you think basically what the goal is to make hair transplantation dummy-proof? Any physician could have it in their practice, have this device in their practice.
Well, again, there's still the like everything else, patient selection, the design, the use of medications, all those other.
I agree with that,
really
Doc,
critical.
and I know that this is something that you truly believe in. But the truth is that once this becomes considered dummy-proof, everyone's going to get one. It's going to be in almost every dermatologist's office, which is good. It's good that it would be in a dermatologist's office because at least they understand hair. But, any doctor who's getting into cosmetic surgery is going to have the ability to get one of these machines if they can afford it and start a hair restoration practice. And like you said, even if the machine is extracting the grafts, and even if the machine is doing the complete design and even inserting the grafts, there's still certain nuances that only an experienced physician would understand, even when they're calibrating the machine to actually create the hairline in whatever. I mean, there's got to be. Listen, it's great for hair restoration. As far as I think, more guys are going to choose to have surgical hair restoration now that there's going to be a procedure that's going to promise less downtime, faster healing, that is more automated, that is practically dummy-proof. So it's going to grow the field, and more guys are going to have hair in their head. But I still think there's going to be a lot of damage done.
Yeah, totally agree.